Welcome back, friends. Our talk here will be on cholinergic antagonists, and this is a continuation of our discussion of the autonomic nervous system. Here, talking about drugs that affect the cholinergic system, in this case, antagonizing them. If you haven't already, please consider subscribing to my Patreon at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner of your screen, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, forming a differential diagnosis, and treatment plan, things that should come in handy for you as you gear up to study for Step 3 of the USMLE. Thank you very much in advance for your consideration. So we're going to briefly recap the muscarinic and nicotinic receptors, as they're going to be important here as we talk about cholinergic antagonists. I do talk about this in greater detail in the autonomic nervous system section. Then we'll talk about some of the cholinergic antagonists. We really divide this up into 3 different types: antimuscarinic agents, which primarily target the muscarinic receptors; ganglionic blockers, which have absolutely no use in modern medicine, but they do come up from time to time on USMLE Step 1, so if you're taking that test, you'll want to be aware of those. And that's not to say that they're not important, because there is one particular drug of abuse that we're going to talk about that does affect these NN receptors. We'll talk about neuromuscular blockers, even though this is part of a wider arc on the autonomic nervous system, and neuromuscular blockers don't affect the autonomic nervous system. You can't talk about cholinergic antagonists without talking about neuromuscular blockers, and now would be as convenient a time as any to talk about them, so we're going to bring them up briefly, I suppose, but it is good to know for anesthesia. And then we will recap at the end. So these are your pathways in the autonomic nervous system. So remember, the autonomic nervous system is just a subdivision of the peripheral nervous system. You have your parasympathetic. All of these work by synapsing, and at the synapse you have your NN, or also known as NG receptors. Either or, it's the same thing. So at the synapse is where you have your NN receptors, and those are both going to exist on the parasympathetic and sympathetic divisions. And then at the target organ, you may have muscarinic receptors. That's primarily going to be featured in the parasympathetic nervous system. You do have muscarinic receptors as part of your sympathetic nervous system, but that primarily is only going to affect the sweat glands, not any other target organs. And then remember, as your sympathetic nervous system, your primary receptor at the target organs are going to be your adrenergic receptors, which we're not going to talk about here. And then importantly, as we talk about the neuromuscular agents, we have neuromuscular nicotinic receptors that sit at the skeletal muscle. It receives acetylcholine, transmits a signal to contract the muscle, and this is a very, very important receptor that is targeted by some of those anesthetic agents. I should say agents used in anesthesia. They don't really cause anesthesia. They are just used in anesthesia. Okay, so our muscarinic receptors, remember, exist on various effector organs in the CNS. They primarily mediate parasympathetic activity, with the exception of the muscarinic receptors that sit on your sweat glands. That is under sympathetic control. You have 3 different types of muscarinic receptors that are of interest to us. There are actually 2 others that have been characterized, but there are 3 that are important to us. The first is M1. Those are primarily on exocrine glands, so that's going to mediate things like salivation, gastric acid secretion. Then you have the M2 receptors. Those are on the heart, so those will do things like slow heart rate and reduce atrial inotropy. And then your M3 receptors, those are going to be on smooth muscle and vasculature. They also exist on ciliary muscle, so when they are stimulated, when these M3 receptors are stimulated, they allow you to change the shape of your lens and allow you to accommodate when you're looking at things close up. You also have them on your sphincter pupillae muscle, so when they are stimulated, they contract the pupil or constrict the pupil, and that is why when you're under parasympathetic control that you get pinpoint pupils. And then they are also on your pancreas. So these I talk about in greater detail in the autonomic nervous system talk. This GQ, GI, important to know for step 1, otherwise I would disregard it. The transmitter for muscarinic receptors is, of course, acetylcholine. Your nicotinic receptors exist on the ganglia of the synapse, the synapse of the ganglia, and that can be found either here in the as part of the parasympathetic nervous system, or here as part of the sympathetic nervous system. They're pretty much the exact same receptor. You also have nicotinic receptors at skeletal muscle, and that's going to be important as we get into that. And then one more place where you do have these NN receptors, that's not going to be a primary focus of our talk here, is at the adrenal medulla. So the NN receptors transmit signals to the postganglionic neurons or to the adrenal medulla. Remember, at the adrenal medulla, when you get a signal there, it allows you to secrete epinephrine into your bloodstream, and then that can go and work at other target organs. At the NM receptor, activation here results in opening of the sodium-potassium channel at the muscle, which ultimately results in muscle depolarization and contraction. And the transmitter for the nicotinic receptor is acetylcholine, again. So when you take your muscarinic receptors and your nicotinic receptors and refer to those together, we call them cholinergic receptors. And so when we talk about cholinergic agonists, those affect both muscarinic and nicotinic receptors, although some cholinergic agonists, some cholinergic antagonists will target one more than the other. So cholinergic stimulation. This is not what the cholinergic antagonists do, obviously. This is what the cholinergic agonists do. However, I would encourage you to remember this list, because if you remember what happens when the cholinergic receptors are stimulated, then when you think of an agonist, you'll know that it does these things. When you think of an antagonist, you'll know that it does pretty much the opposite of these things. So first off, hypotension. Why hypotension? Because you get a reduced peripheral vascular resistance because the smooth muscle of the vasculature relaxes, mediated by those M3 receptors, and then the M2 receptors are going to slow your heart down. So you put those two together, you can elicit a pretty decent hypotension with that. When you have vasodilation, you can get flushing from that because your vessels are just expanding, so it makes your skin look red. You'll also get increased secretions mediated by M1 receptors. That's going to be salivation, gastric acid secretion, intestinal secretions, and then this one kind of doesn't really belong here, but it still happens nonetheless. You can get sweating, and remember that sweating is not part of a parasympathetic response, it's a sympathetic response, but that is the one muscarinic receptor that is actually part of your sympathetic nervous system. And so when you're giving cholinergic agonists, it's going to affect sweating anyway, because that's a muscarinic receptor. It doesn't matter if it's sympathetic or parasympathetic. It just so happens that the cholinergic receptors are primarily in your parasympathetic nervous system. So what you get with cholinergic stimulation is what looks like a parasympathetic response. You'll have increased GI motility. This is again related to smooth muscle. So with smooth muscle contraction, you're going to speed things up in your GI tract. As you do that, you're going to have less fluid absorption, more fluid in the stool, and so that can cause diarrhea. Nausea, I'm not exactly sure how that happens, but I think it just has to do with the GI tract speeding up. And then abdominal pain, and that is your smooth muscle contracting causes some degree of pain, and so patients will report abdominal pain in some cases. Increased detrusor tone. Remember that the detrusor muscle is smooth muscle which exists on the wall of your bladder, and so if you have increased tone, it's going to lead to urinary incontinence. Remember, one of the drugs that we give, a cholinergic agonist, is bethanechol, and that is a great drug to give to somebody who has urinary retention because it's going to increase the tone of the detrusor muscle and help them urinate. However, the problem is when you give cholinergic agonists, you can cause urinary incontinence. And as you're going to see when we talk about cholinergic antagonists, that can be good for patients who have urinary incontinence to make them more continent. And then contraction of the sphincter pupillae muscle, obviously that's going to lead to meiosis. And then bronchospasm, that's smooth muscle again, and smooth muscle will contract under cholinergic stimulation. With the exception of the smooth muscle in your vasculature, that's the only exception. And so you can cause bronchospasm, and that's why we have to be very careful about giving cholinergic agonists to people who have asthma or COPD. Okay, so this is a list of things that happen under cholinergic stimulation. Now we're talking about antagonists, so it is going to do the opposite. Cholinergic antagonists will do the opposite of cholinergic stimulation. And so the very first thing you think of is decreased secretion. You block those M1 receptors, you reduce secretions from your salivary glands, secretion from your tear ducts, And so this is going to cause dry mouth and dry eyes, and this is a major side effect of the cholinergic antagonists, one you'll very commonly hear of. Decreased GI motility, the opposite of cholinergic agonists. So cholinergic antagonists will decrease GI motility, and so that can cause constipation. You have more fluid absorption in the GI tract, it's going to harden the stool. Decreased detrusor tone, that can lead to urinary retention. Relaxation of the sphincter pupillae, that's going to cause mydriasis. Those pupils are going to get bigger. A relaxation of the ciliary muscle will lead to cycloplegia. What you're doing here is you're paralyzing the ciliary muscle. It's a very tiny muscle, so it's very easy to relax it, to paralyze it. And so you will not be able to accommodate. And what that means is that if you try to read something close up, you're not going to be able to read it because you can't accommodate. And so this is why when you go to the eye doctor and they give you a mydriasis-inducing agent, a mydriatic, it dilates your pupils, and so you go outside after your appointment, and the sun is going to be very painful because you won't be able to constrict your pupil. That's the mydriasis. And then if you try and read the newspaper or your iPhone or whatever you have, you won't be able to read the small print on that because you can't accommodate. And so that often gets referred to as blurred vision, but that just has to do with the inability to accommodate. So you won't be able to read small print. And so that gets referred to as blurred vision. So mydriasis and cycloplegia. This can be good when your ophthalmologist or your optometrist wants to do an examination. But if you're receiving cholinergic antagonists for other reasons, this is an unwanted side effect. Bronchodilation, very, very important effect of cholinergic antagonists, and this is the drug ipratropium that you see given for asthma and COPD. You'll see that's very commonly used as part of the drug known as Compavent. And so this is an important, I wouldn't even call it a side effect, because bronchodilation is really a good thing for most people who are getting drugs. And then blockade at the neuromuscular nicotinic receptors, that is going to cause a flaccid paralysis. Again, something really, really good when we're using it for anesthesia. You're not going to get flaccid paralysis really from using the other drugs for other purposes. You need rather high doses of these, that you're not going to be giving doses at that level. And so in order to cause a flaccid paralysis, you really need to give lots of these drugs IV. And so it's really, for our intents, impossible to elicit flaccid paralysis from the administration of these other cholinergic antagonists. So we'll talk about those drugs in a little bit. So these are your cholinergic antagonists, divided up into three different classes. Your antimuscarinic agents, which primarily work at those muscarinic receptors. Ganglionic blockers, which work on the nicotinic receptors, the ganglion type nicotinic receptors, or neuronal type nicotinic receptors, NN receptors. We do not use these drugs anymore clinically. However, one of these, as you can see, is a very, very common drug that is abused, and that is nicotine. Then the neuromuscular blockers, these, like I said, need to be given IV, and so you're not going to get neuromuscular blockade by giving any of these other agents. You do not have to worry about that. So you really have to be intending to get neuromuscular blockade, and that's given, that's achieved by these drugs. Note that there are two different subtypes of these neuromuscular blockers, depolarizing and non-depolarizing. We'll talk about what that is in a few slides. So the antimuscarinic agents, the prototype, I guess you can call it, for antimuscarinic agents is atropine. And atropine has a high affinity for muscarinic receptors. It does penetrate the CNS, as you can see. This is a tertiary amine, and so it is lipophilic and can cross into the CNS. In large doses, atropine can cause confusion, hallucinations, delirium, and coma. Hopefully you're not giving it in such large doses. If you give it in the correct doses, it can have the effect of stimulating the heart, and that is one of the more common reasons why it's given, although it is being replaced more and more now. It has a wide variety of applications, as you can see down here. You do need to use it with caution in older patients, patients who may be predisposed to glaucoma, because remember that anytime you block muscarinic receptors, you're going to narrow off the outflow tract of aqueous humor in the eye, and so that can raise intraocular pressure. Remember that that was an important application of the muscarinic agonists, cholinergic agonists, is to help with the treatment of glaucoma, particularly emergent treatment of glaucoma. So in your eyes, of course, atropine will work as a mydriatic and cycloplegic agent. However, atropine has a very long half-life, and so we don't typically give atropine to achieve mydriasis and cycloplegia. We'll give something else that works a little bit shorter. You don't want your eyes to be dilated for 4 or 5 days. You want them to be dilated for maybe a few hours. Cardiovascularly, it has a dose-dependent response. What you will want to remember is that low doses will lead to bradycardia and high doses will lead to tachycardia. And typically we want to give it in sufficiently high doses to induce tachycardia. Atropine has at least historically been part of your cardiac drugs that you'll give in a code. For patients who need cardiac stimulation, you'll want to just make sure that you give the correct dosage so that you induce a tachycardia. You speed up the heart rather than slow the heart down slower than it might already be. In the pulmonary system, it is an anti-secretory, again here working with those M1 receptors. And so in some cases it may be given preoperatively, particularly for patients who are getting scoped in their respiratory tract, like bronchoscopy. I'm not a surgeon, so I don't really know to what degree this is actually given in practice, but historically, at least, it has been given for that purpose. In the GI tract, it can work as an antispasmodic. That's not to say that it's given commonly for this purpose. Atropine is really a dirty drug because of all the side effects, but I'm just giving you the effects here. The urinary tract, it may be given for urinary incontinence. However, this has largely been replaced by a drug called tolterodine, which I'm not going to talk about in great detail, but you'll want to know that tolterodine is an antimuscarinic, anticholinergic, and this is a very common drug called Detrol that's marketed for urinary incontinence, particularly women who have stress urinary incontinence. And then it's also very important, this is still a very common application, even though cholinergic toxicity is not something we run into a whole lot. Atropine would be your drug of choice for cholinergic toxicity. Now, this is not the same as organophosphate toxicity. Organophosphate toxicity, you're still going to give atropine, but remember with organophosphate toxicity, you're going to give an additional drug called pralidoxime. And if you want to know more about that, go back to my talk on the cholinergic agonists. So there are some other drugs aside from atropine that are given more commonly. Scopolamine is one. This also, as you can see, is a tertiary amine, and it can penetrate the CNS even better than atropine, and it's commonly used for motion sickness. It is also mildly sedating for some reason, and it can interfere with short-term memory, probably because acetylcholine is highly implicated in the formation of memory, which is why we give cholinergic agonists to people with dementia. Ipratropium, big one here. This is a big drug, very commonly given out, typically along with a beta agonist, and this is a drug that's given for asthma or COPD. This is given as an inhaled preparation. As you can see, this is a quaternary amine. It's a salt, and this is not going to cross into the CNS. So it's a very great drug to give for that purpose because it's not going to cross into the CNS, and so you're going to have much fewer side effects than you would have if it were a tertiary amine. Tropicamide, which I don't have pictured here, and cyclopentalate are used as mydriatic and cycloplegic agents, typically by your eye doctor, so that they can get a good look at your retina. Benzatropine and trihexyphenidyl. Benzatropine, very common drug, also known as cogentin, which is given by psychiatrists to reduce the extrapyramidal side effects of antipsychotic treatment. So benzatropine basically works by blocking cholinergic activity in the basal ganglia. It also acts as an atypical dopamine reuptake inhibitor, and that helps it reduce the symptoms of akathisia. And you might be asking, if you're really acute here, you might be asking why we would give something that blocks the reuptake of dopamine if we're giving an antipsychotic, because an antipsychotic is anti-dopaminergic, and that's the way it works. My inclination is that the benzatropine and trihexyphenidyl will actually target that nigrostriatal pathway, which doesn't really help us in the treatment of psychosis, but what does cause those extrapyramidal side effects. So if you give that drug, you can have the effect of reducing extrapyramidal side effects without interfering with the antipsychotic therapy. Benzatropine and trihexyphenidyl are relatively selective for the M1 receptors. So as you can imagine, one of the side effects, big side effects of these drugs is going to be dry mouth and dry eyes. And remember, please, please, please remember that the general contraindication for antimuscarinic agents is glaucoma, because it's going to block off Schlemm's canal and it's going to raise intraocular pressure. So you got to be careful. Some other drugs that have antimuscarinic activity, or you may hear it referred to as just anticholinergic activity, not exactly the same thing, but they get used interchangeably, include drugs that we don't consider cholinergic antagonists, but they do have cholinergic antagonist activity. So these would be things like antihistamines, cipraheptadine, diphenhydramine, hydroxyzine, very common. Cipraheptadine, not so common anymore now that things like Claritin have come out, those second-generation antihistamines, but it has been given for allergies. Diphenhydramine and hydroxyzine are often given for insomnia, so you may see those drugs out there. Antidepressants like paroxetine, which is an SSRI, and the tricyclics. Antipsychotics like olanzapine or Zyprexa, and clozapine. We try to avoid this drug nowadays. Cardiovascular drugs, furosemide, nifedipine, very common drugs. Disopyramide and digoxin. Antivertigo medications like meclizine, and antiviral or antiparkinsonian agents. This drug happens to be both, and that is amantadine. So these drugs also have antimuscarinic activity, and so they can cause similar side effects to what we see with our actual antimuscarinic, anticholinergic drugs. So I will say that with diphenhydramine, hydroxyzine, cipraheptadine, these drugs are very commonly given, and so you'll want to warn these patients it can cause dry eyes. You've probably taken these drugs. If you've ever taken a Tylenol PM, it has the drug diphenhydramine in it, and it can cause sort of that dry, sandy eye feeling in the morning when you wake up. Okay, our ganglionic blockers. We do not give these clinically anymore. We used to. We used to give them to help lower blood pressure. However, they're not given anymore. So it's good to know for step 1, but for the purposes of step 2 and step 3, you can pretty much ignore it, with the exception of nicotine, and that's because it's a drug of abuse. So nicotine is very complex insofar as when it inhibits the ganglionic receptors, it can have kind of mixed effect, and that makes sense if you go back here. Because look at where we have our NN receptors, or NG receptors, same thing. You have them both in your parasympathetic and your sympathetic nervous system. So if you stimulate or block these, you can cause either a parasympathetic or sympathetic response. And you actually, in the case of nicotine, you're going to get a little bit of both. So when you give nicotine, you get mixed sympathetic and parasympathetic manifestations. It can raise your heart rate, raise your blood pressure, but also increase secretions and suppress appetite. Oftentimes, when you have a patient who is withdrawing from nicotine, they may tell you that their appetite goes up. Or you may have patients that abuse nicotine to try to reduce their appetite and lose weight. And so that can be an effect that causes the addiction. At high or toxic doses, it does cause ganglionic blockade and may cause respiratory paralysis. So this is important, not so much for the purpose of what you will see of your patients, but what you would see in the case of a nicotine overdose. Now, you might be asking, how do you get a nicotine overdose? I mean, if you've ever tried smoking a cigarette before, and I regrettably have, it makes you kind of nauseous, and that is exactly because of these stimulatory effects. However, a case where you may see a nicotine overdose, you know those vapors, e-cigarettes? Well, in those with those e-cigarettes, the fluid comes in little bottles. And if you have somebody who has kids and they put those bottles out and the kid gets into it, those are kind of sweet tasting. Like they have different flavors like cherry and strawberry. A kid might get into that and think, oh, this is really tasty. I'm going to drink this. And now you've just flooded that kid with nicotine. And so it is possible from a toxicologic perspective that you may, in fact, see a nicotine overdose. That being said, nicotine is highly addictive. It is accompanied by a withdrawal syndrome of irritability, anxiety, restlessness, insomnia, dysphoria, and appetite changes. Again, sort of a mixed parasympathetic-sympathetic withdrawal effect here. So this is just kind of a side here. It doesn't have anything to do with medications that we give out, but now you have an idea of how nicotine works. Mecamylamine and trimethophan are used very rarely to lower blood pressure. I would just remember that mecamylamine and trimethophan are ganglionic blockers. I would not, because they are not used for therapeutic purposes anymore. So I wouldn't remember them for that purpose. I would just remember them for the academic purpose that they are ganglionic blockers. Okay, so getting to neuromuscular blockade, very important application of medications here, which do have anti-nicotinic effects. And these are used very widely in anesthesia to cause paralysis during surgery. So you will not walk into an OR where somebody's getting general anesthesia without running into one of these medications. There are two different types of neuromuscular blockers, depolarizing and non-depolarizing, and they just differ in their mechanism of action, but they do have some similarities. So the depolarizing neuromuscular blockers, drugs like Succinylcholine, which is really the only one that you'll run into, those cause depolarization at first, which you'd think, well, that's the opposite of what we want to do. So they cause the depolarization. They engage with the nicotinic receptor, cause depolarization of the muscle, but then they stick on that nicotinic receptor. And so you can't get further depolarization unless you have, unless the drug or the acetylcholine, unless it comes off and allows for repolarization, and then you get another stimulation. So if it stays there, then you cannot get further depolarization. So it is depolarizing because it causes an initial depolarization, but then no further depolarization can continue because you have no dissociation between the ligand and the receptor. So when you give succinylcholine, you'll notice that the patient will kind of have some twitches when you give it to them, and that is exactly the mechanism of what's going on. You have depolarization, and then eventually you get paralysis because you have no dissociation between the succinylcholine and the receptor. Non-depolarizing agents are basically just competitive inhibitors. So they don't cause that depolarization, they just inhibit. And so this prevents depolarization altogether. Now, a big difference between these two. With non-depolarizing neuromuscular blockers, because these are competitive inhibitors, you can limit the effect of these non-depolarizing agents by increasing the amount of acetylcholine, because this is a competitive inhibitor. So if you increase the amount of acetylcholine, which stimulates the receptor, it reduces the amount, relatively speaking, of these non-depolarizing neuromuscular blockers. And so, in fact, neostigmine can be used to accomplish this because neostigmine blocks acetylcholine esterase, increasing the amount of acetylcholine at the synapse, and so it essentially inhibits the inhibitor. And so neostigmine is often used to reverse the effect of non-depolarizing blockers. Now, depolarizing agents, you can't use neostigmine to reverse that. So the depolarizing agents, it's succinylcholine that blocks the receptor. It causes depolarization, blocks the receptor, but if you have more acetylcholine there, it's not going to make any difference because the succinylcholine will stick to the receptor. And so having more acetylcholine is not going to do anything for you. So it's only the non-depolarizing agents that can be reversed. Luckily for us, or maybe not luckily for you if you're an anesthesiologist, these medications do not have a very long half-life. They're very unstable, and so you have to often give these medications frequently throughout surgery. And you'll see that with the non-depolarizing agents, there's a very wide variety of half-lives. So this is kind of reiterating what we already referred to earlier. So your depolarizing neuromuscular blocker is succinylcholine. It's the only one you're going to run into. It acts very similar to acetylcholine in that it binds the nicotinic receptor on the muscle. And this is going to cause a depolarization, but because it's not degraded by acetylcholine esterase, it can remain on the receptor. And so it has a very short duration of action, which is a good thing. I mean, we're talking here, it lasts a few minutes, 10 minutes at the most. And so that's a good thing when we're talking about the application of succinylcholine, and that is for rapid sequence intubation. Now, there are two phases of action for succinylcholine. Phase 1 is very similar to acetylcholine. So it's going to associate with the receptor, and it's going to cause muscle depolarization. That's where you get the fasciculations coming in. However, with phase 2, the succinylcholine remains attached. You get repolarization, but you can't get further depolarization because that succinylcholine is still there. And so the only way to get another repolarization or another depolarization is to have the ligand, succinylcholine or acetylcholine, dissociate and then bind again. And that's not what's happening. The succinylcholine is remaining. And so because you can't get a further depolarization, you're going to get flaccid paralysis. So fasciculations and flaccid paralysis. And this is where it differs from the non-depolarizing agents. The adverse effects. Okay, so this is a common vignette on USMLE. Step 1, Step 2, or Step 3. You get a patient wheeled in for surgery. You're going to do rapid sequence intubation, start them up. You give them succinylcholine to help with the intubation, and all of a sudden their temperature jumps up to 104 degrees. What do? Well, the answer to that is you give them dantrolene. In addition, you're going to do symptomatic things like you're going to cool them down with blankets and you're going to terminate the surgery. However, you need to associate the words malignant hyperthermia with dantrolene. What's happening here is you get all this muscle contraction, it increases your temperature, and you get hyperthermia from that. Mechanism, not so important. Just know succinylcholine, malignant hyperthermia, give dantrolene. Very easy point on the USMLE. Succinylcholine, because of all this depolarization that's going on, it pushes potassium into ultimately will push potassium into to the blood, and so you can get a hyperkalemia. And the important thing you need to remember with that is that you should try to avoid succinylcholine in patients who have extensive tissue damage where they may already be predisposed to hyperkalemia. As far as patients who have renal failure, it's probably safe. This is kind of the topic of a lot of discussion, but it's likely succinylcholine is safe for patients with renal failure. However, that is controversial. The non-depolarizing neuromuscular blockers, the prototype is tubocurarine, and tubocurarine, I believe, is used in South America for hunting. They put it on the tips of their arrows, so when they hunt animals, it paralyzes them. Tubocurarine is the prototypical agent for the non-depolarizing blockers, but it's pretty much been completely replaced by other related agents that pretty much do the same thing. Those are things like rocuronium, mivacurium, pancuronium. There's lots of them, and they pretty much just differ on their duration of action and their metabolism. Rocuronium, I would say, is the most commonly used as far as I know. That's the one that I saw a lot on my rotation, and rocuronium is pretty safe, even compared to the other ones. So that would be the one I would remember, but anything that ends, that has the letters CUR in it is derived from tubocurarine as a rule of thumb. So rocuronium, mivacurium, pancuronium, vecuronium, etc. The action of these non-depolarizing agents is enhanced by halogenated hydrocarbon anesthetics, things like sevoflurane. And so they're often given together in surgery, and that's a good thing because they both do different things, but they also both enhance each other. That's good for surgery. These may be reversed by neostigmine. Remember, these are competitive inhibitors. These do not cause depolarization. They just block the receptor. And so if you increase the amount of acetylcholine at the synapse, which is something neostigmine does by blocking acetylcholine esterase, you're going to increase the amount of acetylcholine, and you can kind of crowd out the non-depolarizing neuromuscular blocker. What you will see with these non-depolarizing neuromuscular blockers is there's a sequence of paralysis. So the small, rapidly contracting muscles will be paralyzed first, like the muscles in your face, very small muscles, finally followed by the diaphragm. So you have this sort of sequence that goes on. So it takes a higher dose to paralyze the diaphragm, which is usually the goal, than it does to paralyze the smaller muscles. The adverse effects of these drugs are few. With tubocurarine, we stopped using that drug because it can cause hypotension, but with the other, and that's hypotension with no, with the other drugs, there are very few side effects. Some of the agents may cause histamine release, which can result in a mild hypotension, flushing, and bronchoconstriction, but for the most part, these drugs are pretty safe. And you will see different degrees of adverse effects depending on the exact agent that you're using. You don't need to remember that. You're not going to be responsible for that on the step. What you do need to know, though, is that tubocurarine is not used because of hypotension, and that we prefer to use these drugs in conjunction with halogenated hydrocarbon anesthetics because it enhances their action. But we're usually giving those anesthetics for other purposes anyway. So to recap, cholinergic blockade at the muscarinic receptors will result in dry mouth, dry eyes, mydriasis, cycloplegia, which gets often referred to as blurred vision, constipation, and urinary retention. These can be side effects or they can be desired effects, depending on why you're using them. Some specific cholinergic antagonists, the antimuscarinics is the biggest class here. Atropine is given as an antidote for cholinergic toxicity and organophosphate poisoning. Rarely it's given for spastic disorders of the GI and urinary tract, but for the most part it's been entirely replaced. That's just for historical purposes. Scopolamine is given for motion sickness commonly. Ipratropium, very common drug, given for asthma, COPD, and it can be given intranasally as a nasal decongestant. Tropicamide is given for the induction of mydriasis and cycloplegia, and then you'll see benzatropine and triaxophenidil, which is given by psychiatrists for the extrapyramidal symptoms that is caused from antipsychotics, and it may also be used for Parkinson's as well. Very similar reason that we give them is because of that mechanism of action working on the basal ganglia. The neuromuscular blockers are given for anesthesia. Remember that succinylcholine is your depolarizing agent, can cause malignant hyperthermia, which you would reverse with dantrolene. And tubocurarine, which we don't give anymore, but we do give similar drugs like rocuronium and mivacurium. These are non-depolarizing agents. They can be reversed by increasing the amount of acetylcholine at the synapse. That's why you'll see anesthesiologists often giving neostigmine after surgery to reverse the effect of these neuromuscular blockers, these non-depolarizing neuromuscular blockers. And these are often given and are enhanced with halogenated anesthetics. If you have any questions, write me a note below. Otherwise, I'll see you in our next talk.